Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent sponsorship from Johnson & Johnson.
This program is presented by Medscape Education Global.
Hello everyone. The treatment landscape for EGFR-mutant non-small cell lung cancer is rapidly changing. Until recently, we've used osimertinib as a single agent, which is a very effective drug. But unfortunately, the vast majority of patients will see the cancer progressing after approximately 19 months. And we also know that up to 35% of patients will not be fit to receive any subsequent line of treatment. And therefore, over the last few years, a number of intensification strategies have been evaluated in clinical trials to try and improve outcomes when compared to single-agent osimertinib. And these strategies have evaluated the combination of platinum-based chemotherapy plus osimertinib in the FLAURA2 study, but also a chemotherapy-free strategy evaluated amivantamab, which is a monoclonal antibody, plus lazertinib, which is a third-generation EGFR tyrosine kinase inhibitors. And these two intensification strategies have been proven successful and are now included as options in the current ESMO guidelines for EGFR-mutant non-small cell lung cancer. The FLAURA2 study was a large phase 3 randomized clinical trial evaluated patients with advanced EGFR-mutant non-small cell lung cancer with common EGFR mutation and treated disease who were randomized to receive single-agent osimertinib or the combination of platinum pemetrexed plus osimertinib for 4 cycles, followed by maintenance osimertinib and pemetrexed until disease progression. The primary endpoint of the study was progression-free survival by investigator. It is important to point out that patients who were enrolled in the FLAURA2 study were all screened for the presence of CNS metastasis, but only patients who had CNS metastatic disease at the outset were followed up longitudinally with serial brain scans. The study was a positive study. FLAURA2 demonstrated that the combination of chemotherapy plus osimertinib achieved a longer progression-free survival when compared to osimertinib alone at 25.5 months versus nearly 17 months, with an hazard ratio of 0.62, which is a reduction of the risk of progression by 38%. We also saw the others presenting progression-free survival and the impact on high-risk subgroups. There was a longer benefit in terms of progression-free survival favoring chemo-osimertinib over osimertinib in patients with brain metastasis at baseline. But when the others looked at the impact of the combination of a single-agent OSI for patients whose disease also had a p53 co-mutation at baseline, there was no difference. We had a recent presentation of the second interim overall survival analysis. There was a trend toward a longer overall survival favoring chemo-OSI, which didn't reach the pre-specified threshold for significance. But what about the safety profile? The addition of chemotherapy to osimertinib increases the incidence of adverse events, which is something that is not surprising. In particular, patients who received chemotherapy plus osimertinib had a higher incidence of chemotherapy-induced side effects, such as bone marrow toxicity, namely anemia, thrombocytopenia, neutropenia, but also nausea and appetite loss. There was also a slight increase in terms of LFT derangement. What was reassuring to see was that the incidence of interstitial lung disease was very similar between the two groups at 3%. Mariposa, on the other hand, evaluated a chemotherapy-free strategy. These were patients with untreated EGFR-mutant non-small cell lung cancer, again, common EGFR mutation, who were randomized to receive amivantamab, which is a monoclonal antibody which addresses MET and EGFR, plus lazertinib, which is a third-generation EGFR tyrosine kinase inhibitor, or osimertinib or lazertinib. Patients were stratified according to the type of EGFR mutation, race, and most importantly, presence or absence of brain metastases at the outline. The study was powered to demonstrate a difference in progression-free survival between amivantamab plus lazertinib and osimertinib. The primary endpoint was PFS by blinded radiological review, and very importantly, all patients were screened for brain metastasis at the outset, but also patients without CNS metastatic disease were followed up with serial MRI brains every 6 months. Mariposa, at the first data cutout, demonstrated a longer progression-free survival favoring amivantamab plus lazertinib over osimertinib, 23.7 months versus 16.6 months, with an hazard ratio of 0.7, which means that amivantamab plus lazertinib reduces the risk of progression by 30% when compared to osimertinib alone. The authors also presented the data on the impact of ami-laser over osimertinib on PFS across high-risk subgroups, and there was a longer progression-free survival in patients with brain metastasis and liver metastasis at baseline, also patients with p53 co-mutation, and patients who had detectable baseline EGFR mutation on ctDNA. Very recently, we have seen the presentation of the final protocol-specified overall survival. There was a longer overall survival favoring amivantamab plus lazertinib over osimertinib. The median was not reached in the amivantamab lazertinib arm, and it was 36 months in the osimertinib arm with an hazard ratio of 0.75. But the statistically projection is that the difference is going to be of at least 1 year favoring ami-laser over osimertinib. And this is the first time that a combination strategy has demonstrated an overall survival advantage when compared to osimertinib alone. Very recently, we've also seen an update on intracranial progression-free survival and the duration of response. The combination of amivantamab and lazertinib increases the intracranial progression-free survival, which is due to a very good penetration of amivantamab in the CNS. And most importantly, these responses in the brain are durable. In fact, there was a longer intracranial duration of response for patients treated with amivantamab and lazertinib versus osimertinib at 35.7 months versus 30 months. But what about the safety profile? So the safety profile of amivantamab and lazertinib is certainly peculiar when compared to osimertinib, and the adverse events in patients who were treated with ami-laser were increased in terms of incidence, and the adverse events were mostly driven by EGFR and MET inhibition. We saw more paronychia, more rash, more stomatitis and pruritus in the amivantamab lazertinib arm, together with more incidence of low albumin and peripheral edema, which is due to MET inhibition. Amivantamab in the Mariposa study was given as an intravenous administration, and being a monoclonal antibody is associated with infusion-related reaction. These are usually mild, happen with the first cycle and doesn't repeat afterwards. We also see an increase of thromboembolic events in the amivantamab lazertinib arm, which was then mitigated with a protocol amendment of offering at least 4 months of thromboprophylaxis for patients in the amivantamab lazertinib combination. Again, reassuring to see that the rates of interstitial lung disease or pneumonitis remained low at 3% and were very similar between the two arms. The second line and beyond treatment landscape is also changing very rapidly, and we have had another study which has demonstrated a newer successful strategy, which is the combination of platinum pemetrexed plus amivantamab in the Mariposa 2 study. The Mariposa 2 study was a phase 3 randomized clinical trial which evaluated patients whose disease had progressed after osimertinib as a first or second line, had a good performance status, common EGFR mutation, and patients were randomized to receive chemotherapy plus amivantamab and lazertinib, or chemo plus amivantamab or chemotherapy alone. And the dual primary endpoint of the study was progression-free survival by independent radiological review for chemo, amivantamab, lazertinib versus chemo, or chemo plus amivantamab versus chemotherapy. Mariposa is a positive study demonstrating that the investigational arms, i.e. the addition of amivantamab and lazertinib or amivantamab plus chemotherapy, had a longer progression-free survival versus chemotherapy alone, with an hazard ratio of 0.48 for chemo versus chemo amivantamab, by 0.44 for chemo versus chemo plus amivantamab belazertinib. And there was also a longer intracranial progression-free survival for the investigational arm, again reinforcing the penetration of amivantamab in the CNS. Looking at the adverse events profile, very similar to what I've shown you for the Mariposa study, there was an increased incidence of adverse events in the investigational arm, mostly driven by EGFR-related adverse events, rash, paronychia, pruritus, stomatitis, but also diarrhea. And there was an increased incidence of MET-related adverse events, such as low albumin or peripheral edema. There's a number of strategies that now are going to be implemented to reduce the adverse event profile from amivantamab, and one is the exploration of subcutaneous amivantamab formulation, which was evaluated in the Paloma studies. Paloma 1 was the phase 1 study, and then we have Paloma 2 and 3, which evaluated in a phase 2 and 3 setting, respectively, subcutaneous amivantamab in different combinations for EGFR mutant non-small cell lung cancer mutations, but also for EGFR exon 20 insertion mutations. And subcutaneous amivantamab was developed to improve convenience and quality of life for the patients. What these studies showed was that patients received subcutaneous amivantamab. There was a reduction in terms of incidence of infusion-related reaction, but also thromboembolic events, and the administration time is less than 5 minutes, which is much shorter than what will happen with the intravenous formulation. Very importantly, the studies also looked at patient-reported outcomes, and the vast majority of patients were satisfied with the subcutaneous administration, and they preferred it over the IV administration. And approximately 80% of the patients, when asked, they were going to recommend the subcutaneous injection to another patient. So the Mariposa 2 study had led to approval by EMA and FDA of the combination of chemotherapy plus amivantamab for patients whose disease has progressed after osimertinib as a last line of treatment. But also a number of other trials evaluating different strategies in the second line and beyond landscape. We do have studies evaluating fourth generation EGFR TKI, studies evaluating the combination of chemotherapy plus monoclonal antibodies, which are dual targets of PD-1 and VEGF. We have studies evaluating osimertinib plus a MET inhibitor. And then there's a lot of interest in antibody drug conjugates. And some of these drugs are evaluated specifically in the EGFR mutant setting. To give you some examples, we have the anti-HER3 ADCs, such as patritumab deruxtecan, the MET antibody drug conjugates, like Telisov, and then the anti-TROP2 antibody drug conjugate, datopotamab deruxtecan. These agents are currently being investigated in phase 2 and phase 3 studies, and we will need to see the results in due course. So we've gone from very little options to several options in the first line setting. We have a new option in the second line setting. This is all good news. But from a clinical point of view, we will pose the challenge on how to define what's the most appropriate sequence in terms of a strategy. I think it's very important that we continue to offer clinical trials to our patients, because that's the only way to inform the next steps, and most importantly, is the only way to maximize efficacy and spare unnecessary toxicity. Thank you very much.
Hello, everybody. I'm going to speak now about side effects of EGFR treatments. My name is Emma Holkyard, and I work as an advanced nurse practitioner at the Christie Hospital in Manchester in the UK. So specialist nurses will be well familiar with use of EGFR inhibitors to treat EGFR-mutated non-small cell lung cancer, and most often with the third-generation drug osimertinib, which is typically associated with disruption of bowel function, of skin reactions, and nail toxicity. However, there is now a distinctly new classification of drug which is available for treatment of EGFR-mutated non-small cell lung cancer. So amivantamab is a bispecific antibody which targets both the EGFR and MET receptors on the tumour. And because it has activity against the EGFR receptors, we commonly see that skin toxicity with rash and potential nail toxicity associated. But because it also targets those MET receptors, we also see side effects such as edema. Thinking also about the third generation lazertinib, which has been administered concomitantly with other treatments for EGFR mutated lung cancer. That drug is associated with novel side effects such as increased propensity to blood clots. So, important to think about how we manage these side effects. And I think one of the key messages is around grading toxicity, because if we can accurately describe and grade the toxicity, that will inform how we manage these side effects. Skin reactions can be wide ranging. Patients can experience dry skin, itching, redness, and rash. And important to describe the rash, the distribution of any rash, and the extent of it. Patients can experience delayed healing, inflammation, infections, and photosensitivity. So I think one of the crucial roles of the specialist nurse is around preventative treatment, so that we can try and prevent these toxicities arising as much as possible. So avoiding frequent hand washing, advocating use of high sun protection factor sunscreens, regular moisturizers, and soap substitution, potentially with an antimicrobial agent, and in some centres, prophylactic use of oral antibiotics. And this is termed an enhanced dermatological approach to managing skin reactions. So, referring here now to the ESMO guidelines, and this is where I talk about how important it is to grade toxicity. The grading includes also the extent that the body surface area is affected. So, head and neck is 10%, front of chest is 10%, and the back of the chest is 10%. So, just as an idea, an indication of what you might think about in terms of distribution and extent. And if we grade the skin reaction, then that will inform what we do in terms of management. So it may be that with early grade 1, 2, we can continue drug. We'd advocate use of an oral antibiotic and potentially low to moderate topical steroids, and reassessment after 2 weeks by the healthcare professional. But the guidelines also note that the patient should be part of that assessment. So it might be by patient self-report. And that really speaks to how important it is to educate our patients to be proactive in monitoring for skin reactions. Grade 3 or intolerable grade 2 skin toxicity might require interruption of drug, swabbing for infection, and treatment of any identified infection with systemic steroids, systemic antibiotics. And ultimately, if we can't get on top of this toxicity, may lead to drug discontinuation. Thinking about paronychia, again, when in the early stage, it's about preventative interventions. So, encouraging gentle skincare, use of soaps, wearing of gloves, and using dressings. But when there's disruption of the nail fold and there's edema or erythema, that's a grade 1 toxicity. And it may be that you can continue drug and escalate that topical intervention with antibiotic and steroid. Grade 2 is further escalation. We'd be thinking about oral and systemic treatments for management, and grade 3 or intolerable grade 2 might require interruption of that anti-cancer treatment and referral to experts in dermatology and podiatry. So thinking about that separate classification of drug, amivantamab, the bispecific antibody, and I think the important message here is around what we know is commonly associated with the drug, and that is infusion related reactions. And I think the role of the specialist nurse here is around counselling our patients, essentially advising them that these reactions can happen commonly. Most patients will experience them. That might be chills, breathlessness, flushing, nausea, vomiting, and chest discomfort. And less commonly, there would be cardiovascular changes. But I think the important message here is around the specialist nurse role in counselling patients, that this can commonly occur. However, with appropriate management, so pre-medication, interruption of the infusion if it were to occur, restarting at a reduced rate, For most patients, they will complete cycle 1 and will go on to receive cycle 2 and subsequent cycles. So it's about providing that upfront support and advice and counselling to our patients. So why is management of drug side effects so crucial? A survey conducted by a UK charity, EGFR-Positive UK, which surveys its members annually. And my colleague, Professor Jeannie Harrison, in her chapter, speaking about patient experience, will talk about this in more detail. So thinking about the most frequent side effects, skin effects are there, paronychia, nail changes are there, but important to note that these may not be the side effects that cause most distress to patients. That lack of energy, disruption of bowel function was actually ranked higher for patients ahead of dry skin and other side effects. The charity asked what makes it worse or better for patients. And I think this is really interesting because what we're seeing here, and it's really valuable for us as healthcare professionals to note, that these interventions are not necessarily described in those ESMO guidelines. So encouraging our patients to drink plenty of water is helpful, to get plenty of sleep and rest is also helpful. Adopting interventions that might help manage stress, which of course is really important for our patient group, and that might be adopting distraction interventions, meditation, tapping, exercise, walking, drawing and gardening were listed as some of the activities that might be adopted. Avoiding sun exposure, avoiding perfumed soaps, and the value of engaging in social support from peers and other members of the EGFR positive community. But also, I think that speaks to that social and psychological support that specialist nurses can deliver either in the clinics or being available at the end of the phone. So this is a little bit more about the patient's voice and what quotes the patients made when they were surveyed by the charity. One patient said, "Please ask about our whole quality of life and don't just be concerned with killing cancer cells." And there's a note here about the mental side, the sheer fear, needs more help and advice, potentially a collated list of possible side effects and ways to deal with them would be great to refer to. And also be open about possible side effects, not just lists, as we're all very different. So who can help us? Acute oncology is probably the first point of contact. They may be responding to a 24-hour helpline. Important for us to refer to oncology pharmacists who have a working knowledge of medicines available at your local hospital formulary. Of course, engaging with dermatology and that expertise, and the palliative care team, sometimes called supportive oncology, have expertise in managing cancer symptoms and also the effects of anti-cancer treatment. So in terms of future treatment considerations, what we're seeing increasingly is the potential for combination therapies. So oral TKIs in combination with chemotherapies, or these bispecific antibodies in combination with other drugs. And it may be there are specific disease characteristics, the presence or absence of intracranial disease that points to one intervention over another. Novel combination therapies bring novel side effects, edema for those with MET inhibitory action activity. And we need to think about how that might impact on our patients. The potential for increased blood clotting. And so we have to think about how we manage that, particularly if our patients take concomitant blood thinning medication. And also those infusion-related reactions that I described with amivantamab, and the role of the specialist nurse in counselling our patients. And I think the key message is around engaging with our patients so that we can make the right decisions for them, so that they can have the best experience possible on their anti-cancer treatment, and so that we can prioritise their hopes and their wishes for future. Thank you.
Hi, I'm Ginny Harrison and I'm a trustee for EGFR-Positive UK, which is a patient-led charity to support those affected by EGFR-mutated lung cancer. And I myself was diagnosed in December 2021. I'm not going to talk about my own experience so much today. I'm going to talk more about patient experience more broadly. Every year at the charity, we run a member survey that really looks at patient experience from initial symptomatology all the way through diagnosis, treatment, and to today, just to find out really what their experiences are. And when thinking about the challenges that we as patients really face, that initial diagnosis is actually one of the really big ones. We tend to be diagnosed quite late when curative treatment is really rare. And there's a couple of reasons why this might happen. So first of all, there's a real absence of the typical risk factors that you might see or expect to see in lung cancer patients. About a third of our patients reported having a cough, but that means 2/3 didn't. And equally, a quarter had breathlessness, but that means 3/4 didn't. And actually, a lot of people, myself included, suffer from more musculoskeletal pains like shoulder pain or back pain, which you wouldn't typically think of as lung cancer. And actually, more than half of lung cancer patients don't actually realise that they themselves are at risk of it. And because of this, it can really delay the time it takes for us to seek treatment. So a total of over 65% delayed seeking medical advice after experiencing symptoms, largely because they just didn't recognise those symptoms as being lung cancer, or they attributed them to something else. And in our surveys, around a third of respondents reported that they made 3 or more visits to the GP before they were actually diagnosed. And it's not just at that initial diagnosis either of lung cancer more broadly, it's also to do with delays in treatment for then finding out if there are any specific targetable drivers that might be driving that cancer, in this case, EGFR mutations. And this is huge because whilst you're in this situation where you know something is wrong, but you haven't yet found out exactly what the issue is, you're in this limbo of anxiety. So anything that can be done to speed up these diagnostic delays would be really beneficial on patient quality of life. Now, once the EGFR mutation is identified, the majority of our patients are treated with TKIs, oral tablets that you can take at home, 1 single tablet a day. And most of our patients refer to this as things like their magic medicine. They find it absolutely amazing because they're able to basically live a relatively normal life while taking it. They're not tied to hospitals like you would be with chemo. So generally, in terms of quality of life, people really appreciate these drugs. However, there are a number of side effects, and we asked our patients to tell us what those side effects were using a modified Memorial Symptom Assessment Scale. And we asked them about both frequency and distress, which I think is really important because how distressing we find those symptoms really feeds into our quality of life. And our top 10 kind of most distressing symptoms were lack of energy and diarrhea, dry skin, muscle cramps, rashes and acne, but also things like feeling drowsy, changes in hair texture and mouth sores. And they were all found to be relatively distressing, but the good news is not terribly distressing. And most patients found that these physical symptoms they were able to manage them quite well. However, the sort of psychological impact of these side effects is also quite large. So, for example, acne was seen as really affecting self-esteem. People didn't necessarily want to leave the house. Muscle cramps were debilitating. And even mouth ulcers, which can seem really small and insignificant, can profoundly affect quality of life. So I think it's really important when looking at side effects and not to just think about the physical aspect of them, but also the psychological impact that these side effects can have. And one other thing to mention is that we found that some of our patients are actually quite hesitant to talk about the side effects because they were really worried that if they told them, they might be taken off their medicine. So I think communication around what side effects are likely to happen and the fact that we can manage them quite well is really important and can help alleviate some of that anxiety that the patients were experiencing. We also looked at anxiety and depression more broadly. And we found that 1 in 3 have levels of anxiety that could be clinically diagnosable. And we found 1 in 4 have the same with depression. So these are much higher than what we see in the general population. And to give a better impression of what it's like, really, to experience EGFR positive as a patient, but also as a loved one, I just want to show you this video, which gives you real insight into the patient experience.
It's that connection with nature. And it's that living in the moment, and it's almost like a moving meditation as well when you're walking. When somebody mentions lung cancer, you can't comprehend it. You can't understand it. If they'd said to me, you've got breast cancer, you've got ovarian cancer, you've got cervical cancer, I could have understood those, because those are the type of cancers somebody of my age, somebody, female, youngish female, tend to get. The fact that I was being told I had lung cancer, I found that really hard to understand. When I first of all met with my oncologist and he sat down and he showed me and talked to me about different treatment options, I remember just being absolutely flummoxed. It was so complicated. There were different trials, there was radiotherapy, there was surgery, there was chemotherapy, there was immunotherapy. And again, it was a whole new language. And I remember I just wanted him to tell me what it was that I needed to do.
Speaking to the consultant and hearing firsthand what the diagnosis was, what the treatment plans were, what the options were, gave me knowledge. I can then, as well as help Natasha rationalise the discussions and dissect it, I was also there to let Matt know if he was unable to come, or mum and dad, which I think helped the whole family, that there was two people that had that knowledge, had the information and could rationalise it.
The lung cancer nurse suggested that we send my bloods off to be tested in Germany in a trial that would be looking for a genetic mutation. Because of my age, because of my age and because of my non-smoking status, she thought it was highly likely that I would be EGFR positive, and she was right. I remember her saying to me, it's really good news. This is absolutely brilliant news. It means you can have a targeted therapy that works as a blocker and it's highly effective. So it felt like I'd been given a lifeline, because I didn't need to have the traditional chemotherapy, immunotherapy, surgery. I didn't have to go down that radiotherapy route. It meant that I could literally just access this targeted therapy that was precision medicine for my genetic mutation.
Natasha is coping very well with the treatment that she's on. If you saw her, you'd never guess that she had stage 4 lung cancer. She does get very tired though. There's other side effects as well, which, for example, her skin is more sensitive, and internally as well, that can be a struggle sometimes.
I think initially, when she was first diagnosed, it was a shock, and it took a while for everybody to take it in. I think the longer it's gone on, the almost easier it's got, because she's okay at the minute, but the longer it goes on, the worry you have is that the treatment's not going to last forever. It's always there hanging over you, and when we have the scans every 3 months, you have that pre-scan worry, and it lasts for weeks, and then she has the scan, and luckily every time it's been okay, and then you have relief for a few weeks, and then it all starts again.
Pre-diagnosis, I was a very busy working mum, and I loved mountain biking and rock climbing, but I'm terrified of falling off because my bones don't heal so well because of the therapy I'm on. I need to make sure I do not break anything. When I'm out with the dogs, I can't help but smile. They just make me laugh, and they're just really daft and really funny, and they just bring me so much joy. Just watching them play, watching them run round, they're just an absolute delight.
So the video showed just how much of an emotional rollercoaster it can be as a patient to experience this diagnosis. But it also highlighted something quite important, which is around the information that we get as patients and how confusing it can be at the initial diagnosis, particularly because suddenly we have to learn this whole new language, and it is a huge amount to take on. And this kind of maps on as well to the results from the Lung Cancer Europe recent survey on knowledge and decision-making in lung cancer patients. And they found that patients feel like it's really important for us to be informed. 98% of patients who answered that survey said that they believed their opinions should be considered when it comes to deciding about treatment and their care. but 50% felt they weren't involved in that process. And a lot of the time that was due to the information that they were given. Just it felt too complex for them. They didn't feel like they were given adequate information to help them make those decisions. And these informational challenges aren't just around your sort of cancer care treatment. They also extend to wellbeing support. So going back to our EGFR survey, we've asked patients whether their hospitals offered them any counselling or psychological support. And we found that while almost half said that their hospital did, worryingly over 40% said they didn't know if their hospital offered that kind of support, which really shows that there's a gap in communication there. And this kind of translates into treatment disparities, because if patients don't know what's available to them, how can they access it? And there's disparities in care as well. We found this in terms of surveillance. So whilst the majority of our patients were receiving regular CT scans, only just over a third received regular brain MRIs. And those who didn't receive them, most of them said that there'd never even been any discussion of it as an option, which is potentially problematic because brain metastases are really common in EGFR lung cancer. In terms of progression, there were also disparities in care. Of those who had progressed, only 40% of respondents who progressed were offered a rebiopsy. So that's less than half. It seems like that's really being missed out there and is a real opportunity to improve the care that patients get. So overall, really, I just wanted to highlight that EGFR patients are really quite unique in terms of lung cancer. We tend to be younger, we don't have the smoking histories, our symptoms don't necessarily map onto your typical lung cancer symptoms, which often contribute to delayed diagnosis. And while treatment advancements are happening quite quickly at the moment, they do also bring with them side effects that need to really be looked at and managed, because they can massively impact quality of life. And in terms of psychological issues, we found that they were really prevalent patients. In terms of information and shared decision-making, many patients felt that they really wanted to be involved in this, but often felt that the information given to them just wasn't appropriate or it was too complex to understand. So I think more around patient education would be really beneficial. So improving communication and support is really essential, and equity of care as well. And it really feeds into quality of life and patient outcomes. And as one of our patients said, we need more than tumour control. We need whole person care. And that's what I wanted to end with, really. So thank you.
Hello, everybody. My name is Raffaele Califano. I'm a consultant medical oncologist at the Christie in Manchester and honorary professor of medical oncology at the University of Manchester. I welcome you to this segment titled Navigating the Patient Journey Together, Collaborative Care, and our discussion will focus on EGFR mutant non-small cell lung cancer. I am very pleased to have with me today Emma Orchard. Emma is the lead nurse and advanced nurse practitioner from the Christie Hospital in Manchester. And I also have Professor Ginny Harrison. Ginny is a patient advocate for EGFR-positive lung cancer UK and also a professor of psychology at the Open University in Milton Keynes in the UK. So welcome. Let's start with taking a look at the patient journey and testing for EGFR mutation, this time in the treatment-naive setting. Ginny, which are some of the psychological issues around testing, waiting times, for example, and how we can address these?
I think one of the main issues is actually the sort of management of expectations with patients around how long the testing will take and why it's needed. Because actually, if you ask any patient, say that initial phase where you know something's seriously wrong, but you haven't got your test results back yet, is actually almost one of the worst bits, because you're just waiting in this kind of fear, but you're not actually doing something about it yet. So it can be really anxiety provoking, absolutely horrendous to live through in terms of quality of life. It has a huge kind of negative impact. So I think managing expectations and just being really clear with patients on what's needed, how long it's likely to take, why it needs to be done is just really important, because I think that helps us manage anxiety that we feel.
Thank you. And I think it is very important from a medical team point of view to explain why we are running these tests and the importance on having the results to give the best available evidence-based treatment to the person in front of us. But as you said, it's also important to acknowledge that sometimes these tests are run in a different center or genomic hub, and there will be transition times, there will be running times. And also, I think it's important to mention that sometimes there is a risk of failing the test if the specimen that has been sent has got a limited amount of neoplastic cells.
Yeah, and I think we see that quite a lot now, don't we? Liquid biopsies, sometimes you'll get these negative test results back. So I think explaining what the different ways of biopsies are and the benefits of doing them can be really helpful as well.
And on that point, I think it's also important, again, to explain that if you have a negative results on the plasma NGS or plasma testing, that doesn't mean that there is no actionable mutation, because we know that the false negative rate with plasma is much higher than tissue. So plasma will certainly be helpful in speeding up the diagnosis if you have an actionable genomic alteration which is identified. But if not, the next step will be to wait for the test on tissue, which will give us most of the time a definite answer. If we move then to when unfortunately the cancer starts to progress from the first line therapy, which are the consideration from a patient perspective around treatment resistance, disease progression, and the need for further biopsies and retest?
Yeah, again, I think this is really important. So we've run a survey with our patients that's basically shown that only 40% of patients who've had progression have been offered a rebiopsy, which is much lower than we'd like it to be, because as they develop treatment resistance, they can get new mutations. So without doing that testing, you won't know whether there is potentially another targetable mutation, that there might be a different medication out there that they can take. So we're trying to get the message across to our patients that it's so important to ask for a rebiopsy at progression, whether that's liquid or tissue, depending on what's most appropriate, because that can really help guide what the next step is in terms of treatment.
I think you're absolutely correct. And it's again down to the managing medical team to explain that unfortunately we're in a situation where the treatment is stopping working, and in order to guide what's the most appropriate next steps, if feasible, if safe, we should try and obtain a rebiopsy, either liquid or on tissue, because we may identify a mechanism of resistance which can be addressed in clinical practice, but we may also identify some mechanism of resistance which can be addressed in a clinical trial. And most importantly, there is a 10% chance of seeing transformation to a different kind of cancer, which is, for example, small cell carcinoma or squamous cell carcinoma, which will have a completely different management in terms of chemotherapy backbone. So it's very important that we explain why sometimes we can't just jump onto the next line of treatment without rebiopsy. But I think it's also important that as oncologists, we have a consistent approach in order to offer the same opportunities to patients who are treated everywhere. So that brings me to a very important point. So the communication between the person affected by cancer and the medical team is crucial. How do you feel we can facilitate doctor-patient communication, shared decision-making process for testing and next steps? What do you think about shared decision-making?
I think patients generally feel that they want to be involved in the decisions around their treatment and care if they can be, although some patients, it may not even occur to them that they can be involved, if that makes sense. So often we might not quite understand what's being said. So I think it's just really important both that the communication level is at that right level, and understanding with the patient is continuously checked throughout those conversations. And if possible, just making sure that everything's in the kind of most accessible, easiest language, maybe not even language, maybe there can be other ways of having those conversations or giving information to patients that's not just reams and reams of printouts of information, which is often what we get, these sort of big printed packs that come from different charity websites and things. So I think different modalities of communication, making sure that it's in the most accessible way possible, and just checking patient understanding is so important.
Thank you very much. I think it's important that we explain the options, and we also address any needs from a patient perspective, any concerns, because only if we pull everything together, we can then give the most appropriate patients. Because some patients may not want a very toxic treatment, which may be a bit better in terms of outcomes, and some other patients will accept more in terms of side effects in order to achieve better outcomes. So it is very important that we explain that in a very understandable and practical way, more than just technical terms. Thank you very much. I would like to move to the role of the specialist nurses in the care and management of patients who are receiving FAR inhibition. And therefore, I'd like to discuss with Emma the critical role and the support that specialist nurses give to our patients. We now are witnessing a very fast-moving field. We've gone from basically one option, which is a very good option still, single-agent osimertinib, which is an effective drug, has got very good CNS penetration, but has been now proven to be inferior compared to newer intensification strategies, such as the combination of platinum pemetrexed plus osimertinib, which was investigated in the FLORA-2 study, or the combination of mavimantanab and lazertinib, which was investigated in the MARIPOSA study, which is a chemo-free approach, which has got a different adverse event profile and is a monoclonal antibody, which carries the risk of infusion-related reaction, for example. So, Emma, which are some of the mitigation strategies for these regimens and the adverse events related to these regimens that nurses will need to be aware of in order to support our patients appropriately?
Yeah, absolutely. And what you said is how rapidly the treatment landscape is changing. So I think what's crucial for our specialist nurse population working in this setting is to have a grasp of what each of these treatment options involves in terms of the practical administration and what it will mean for our patients in terms of experience of treatment-related side effects, so that we can, as Jeannie has said, meet and be with our patients and help them to understand and navigate what this will mean for them as an individual. So it's not unusual for us to meet patients in the oncology clinic and they attend with some idea about the treatment that they're willing to accept. So I think translating what these therapies involve and what the potential side effects for each is really crucial. But going a step further, helping them to understand what the potential added benefit may be when we think about combination therapies, what it means in terms of toxicity, but how we can help manage that toxicity. There may be a real tangible fear on part of our patients around treatment side effects. And I think really important for our nurses to emphasize what's possible in terms of managing treatment side effects so that patients can access the best treatment for them as an individual.
Thank you very much. And it's very important also to discuss which are the potential practical strategies to prevent or to address the adverse events, as we now are more and more aware about dermatological prophylaxis regimens and also changing the route of administration. For example, for amivantamab, from IV to subcutaneous seems to reduce some of the adverse events, together with, of course, being more convenient for the patients. And on that note, I think we're seeing more and more treatments, at least in Manchester, being delivered outside the centre, closer to patients' home or at home for some simpler regimens. We have immunotherapies that we can give subcutaneously at atezolizumab. We have recently seen some data at a recent congress for pembrolizumab, now another immunotherapy agent which can be given subcutaneously. And then amivantamab is now also explored as a subcutaneous options. From a nursing perspective, how do you think we can integrate subcutaneous formulation into care?
I think it's a real positive. And my feeling is that our patients want the benefit of attending a specialist centre where they can access those clinicians with the expertise around delivering these novel therapies, expert clinicians who may well have been involved in the clinical trials. But it may be that on a practical note, they don't want to necessarily travel to the specialist centre to receive or to have these drugs administered. And having these subcutaneous preparations really allows us to have that flexibility. The subcut administration potentially means that treatment can be delivered in a matter of minutes. So that really gives our patients a lot of flexibility around choosing when they can receive these treatments, and work that around family commitments, potentially working commitments, because what we hope is our patients will remain well on these treatments and they'll be able to access therapies at their convenience.
Thank you very much. And then last question to you. What do you think could be the evolving role of nursing, specialist nurses, to even better support our patients?
I think Jeannie's touched on it. I think it's around the communication and helping our patients to navigate the treatment options and checking that understanding. I think communication is key, but I think really important that specialist nurses have that expert knowledge around how to support these side effects, whether it is having a knowledge of the enhanced dermatological interventions that we can use to ensure that our patients' experience on treatment is such that they can continue on treatment. Because I think if we can be proactive in managing side effects, it could make the difference between keeping our patients on drug and the potential for them to discontinue drug, which would be, have devastating consequences. And of course, hearing and being with our patients so we understand their experience and understand the perspective of their experience on treatment.
Thank you very much. And it's been a very nice discussion. I would like to thank you, Jeannie and Emma, again, and thank you all for listening.
This program was presented by Medscape Education Global.